Hello, and welcome back to another episode of Health Without the System. I'm Dr. Tim Scott.
And I'm Mia Scott. Guys, welcome back. I am so excited for this episode.
What are we doing here today, Mia?
Well, today launches our first episode of about 10 series that we're going to have before we're gearing up for our Women's Health Summit in October 10th. Mark your calendars. And we have a very special guest, probably somebody that will never be able to be beaten as a guest on our podcast, and that is Dr. Kelly Casperson.
Oh, you blew it. I wanted you to do a big intro first.
Oh, I will. But Dr. Casperson, welcome. We are so excited to have you on our podcast, Health Without the System. First off, I just want to thank you for taking the time to be here. Your work has changed the way that so many providers, and even more importantly, women, have thought about menopause and sexual health and advocating for themselves. And you've really helped make conversation that used to be whispered about feel completely normal. And I think that that has an incredible impact on all of us. So we are honored to have you here today.
Thanks for having me.
Yeah.
And what about anyone? I mean, I don't know if there's anyone who doesn't know who Dr. Casperson is, but what if they don't? Can you just give them a brief introduction here?
Sure. So for anybody who does not know her, she's a board-certified urologist. She's an educator, an author, speaker, host of You Are Not Broken podcast. She does it all. And she's actually...
Did you mention New York Times bestseller?
Yeah, that's a big one.
wondering.
Yeah, and it's an amazing book. I have the audio book and all, and she's become one of the leading voices that's helping women understand their bodies and helping providers deliver better menopause and sexual health care. So once again, thank you so much for taking the time to join us.
Oh, it's my pleasure. Podcasting is my favorite sport.
Good.
That's awesome. I sweat during it, so it has to be
Yeah. This is when I do public speaking, because I wear the Whoop band, I'm like zone 4 or 5. It thinks I'm in a triathlon.
Oh, it's like stress.
So I'm like, this is zone 4 or 5 cardio all day long, and it's the most fun way to do it.
Yeah, my Oura Ring's gonna be like, "Are you working out?" Nope, just talking to Dr.
Just
Casperson.
talking.
Right.
That's cool. So, Dr. Casperson, I would like to just start out. Give us briefly your story, if you don't mind. How did a urologist end up becoming one of the leading voices in menopause and women's sexual health?
Yeah, it's a good question. I think, what the female urologists have, why the female urologists are very unique. There's only about 1,100 of us in America right now. That's about 9%, 10% of all urologists. And what our unique lens on this is the gender bias. And what I mean by that is the gynecologist, who people stereotypically say is the woman's doctor, which we can get into. It's completely biased to put 50% of the population into one specialty. But they don't see how we treat men. And for me, I'm like, we take care of men's low testosterone. We take care of their erections like it's a quality of life issue that actually matters. Insurance covers this stuff. We are taught to have these conversations. When we give them surgery, we consent them for sexual dysfunction. We replace hormones that we remove with surgery. And then over here, with this 50% of the population, we're like, oh, is that important? Right. Yeah. So for me, I think the power of the female urologist in this voice, because there's quite a few of us, is really calling out the gender bias in healthcare. For me, my story, I was private practice urology for about 7 years. Watch out for the 7-year itch in career or marriage. It is real. Mine hit. And I was like, what am I doing? I'm bored. I'm doing the same thing every day, which you'd think like you spend all this time training and then you just repeat this. It's like Groundhog's Day, right? Your same stuff every single day.
I can fully.
And yeah, it's like even in emergency medicine, where shouldn't this just be like dopamine all day long? You're like, nope, same stuff, different Tuesday. And so I think the universe knew I was ready, truthfully, because I had a patient come in who I had treated for bladder cancer, and I was very bonded to her. This wasn't some stranger crying in my office. I was bonded to her, loved her family. And she was crying because of her sexless marriage. And I was handing her the box of Kleenex, and I was like, I do not know how to help her.
Yeah.
No idea. Do the gynecologists know how to help her? So I spent an entire year learning about female sexuality, female sexual function. What does the data say? What are the medications? What of sex therapists? Like 1 year deep dive self-taught before I even started the podcast. And I started the podcast because I realized I wasn't going to help the world enough. Like I was starting to realize how big of a problem this is. Mm-hmm. And I wasn't going to make a big enough difference just seeing people in my clinic, in my corner of the world, right? And so then I started the You Are Not Broken podcast, all about female sexual health. And I joke that sex got me into hormones because people say, well, you know what happens to your sex life with menopause? And I'm like, I don't know. but I'm staring down the barrel at it as much as the next person is. Like, let's learn about that, right? So then I started just peeling back the layers of the onion of like, whoa, not just testosterone, but estrogen also helps. And, vaginal estrogen, pelvic health, that's the urologist wheelhouse, right? I treat everything that can be helped by vaginal estrogens, but started learning about systemic estrogen and, oh, are you kidding me? Like, women live longer on this stuff? Why aren't we, if a man had that medication, they'd all be on it, right? So what's the WHI? Why are we so scared of that? What'd the media do to this? And so it was just like layer after layer of fascination for me. And to be like, oh, you guys, I don't think we have the story right here.
Yeah.
Oh my God, I
agree.
I can't agree with that more. And you actually touched on it. You mentioned something a second ago. You said, oh, that's the urologist wheelhouse, female pelvic health, sexual health. My question is it? How many urologists are doing that out there?
I mean, good question. So like for people who don't know what a urologist is, it's a surgeon of the genital urinary organs, but you can be an adrenal gland specialist. You can be a kidney cancer specialist. You can just take out prostates. So within urology, the female pelvis is actually still very niched. And, I'll get us all in trouble from time to time because people will be like, well, so I just need to go to a urologist for hormones? And I'm like, not all urologists do this. But certainly as a female in urology, we are, women gravitate towards us. And so bladder leakage, prolapse, pain with sex, recurrent urinary tract infections, getting up at night to pee, urinary frequency, blood in the urine. Yeah. You're like the entire genital urinary syndrome of menopause, that's completely our wheelhouse. And not all urologists specialize in that.
Yeah. I mean, I don't even think, even your PCPs and OBs, and like they still don't know how to, most of them still aren't taught or trained into hormones. And that's where we kind of dabbled in it. First we were all about metabolic health and weight loss. And then we realized, well, we can't assess weight loss without optimizing thyroid. And then we just kept going down these rabbit holes of we need to optimize the entire body. And then a few years ago when hormones hit, my really good friend has her own practice as well. And I was like, yeah, I'll never get into hormones. Like, not really my thing.
We really said that.
Yeah.
We're not touching hormones.
Yeah, I'm like, I'm just not my wheelhouse. And then I'm like, this is impossible not to handle.
You really she said that to me. So one day she's like, we can't ignore
We
hormones.
can't avoid it. I'm like,
and
it's
I'm
coming.
Like,
Like
I know. I was afraid you were going to say this.
I
one
know.
Day.
I mean, like, it's so cliched, but it's like, it's mitochondrial health. It's cellular health. Like, it's literally the bricks of the house. And that, the exciting data on like GLP-1s and weight loss is like that plus hormones is, 1 + 1 = 3. And then you're like, well, obviously, if we think about it, from a 10,000-foot view. But here, I think in medicine, we want to find the like abnormal protein and the heterozygous recessive gene, and like we just want to like reduce everything, and then we forget what's staring us in the face is like hormones. They help all cells.
All things. It's like your longevity that you're missing. And that's when majority of our population is peri and postmenopause females because they're coming to lose weight because why? They don't know why they can't lose weight. God forbid, nobody taught them that they lost their hormones or they're losing them. And so once we dove into there, my goodness, has it been such a rewarding career because you're quite literally changing people's lives in a matter of a few weeks,
It's the best thing in the world. I gave up surgery for it.
Yeah.
And I think we learned a lot through trial and error because we jumped into weight management. Everyone was needing it. We wanted to be a good resource for that. But as we started to have people come to us like, I'm doing everything you say. And believe me, we are not like, just take a shot and it's a whole lifestyle approach, hormones, adrenals, thyroid. And people still weren't losing weight. And we're like, what is going on? And that's when I think it really clicked like, duh, we are everything we say you need to be, the entire picture, and hormones are the big picture. And like you said, the GLP-1 patient in the perimenopause, menopausal period, a lot of times when you get the hormones right, and it's just, they start clicking on all cylinders.
Yeah.
And Mia, I think you were the first one to say how impactful it's been to see that change.
As you've probably experienced yourself, you have people crying on your visits saying you've changed my life.
Every single week.
Yeah,
like I feel like myself. Yeah. There is nothing better than somebody saying, I feel like myself.
Right.
Like,
and that's what I tell them. Who am I to judge who you feel like? But, some people are like, you fixed me in the last, 5 years that my PCP continued to say it's just part of aging, which is just like the biggest gaslighting I feel like we could ever do to females. Mm-hmm. But, and this is my goal because you did the exact same thing that I love is you took your audience and your platform and educated the patients that are going to be going to their doctors, because how do we change the masses? Not educate the providers. We create a lot of pissed off females go into those doctors to say, I demand better care. care. And just like me, then you're like, okay, well, now I can't ignore this. And then that is how things change. So you really inspired us to kind of snowball that and get the education out, because there's a lot of females out there that need it. So,
yeah, I mean, to me, it's a...
Yeah. No, go ahead. Go ahead. I'm sorry.
Oh, I was going to say, like, to me, medicine changes from top down and bottom up.
Yeah.
And we got to do both, right? It's a big, heavy ship to turn. We got about 1 million physicians in this country. And we got 2 decades of people that didn't get trained after the WHI, right? Yeah. But there is nothing like, how do we, they're trying to legislate menopause education, all this stuff. Nothing gets a clinician more interested in learning than having 10 women come in that week saying, can we talk about this? Right. So like that's the bottom up that's actually changing the face of medicine more than any sort of like mandate or state law or anything like that, is the patients, coming in and being like, this is what I'm learning about. Can we try it?
Mm-hmm.
I agree. And I think that naturally leads to a question I wanted to ask today, because you are a part of this movement. How do you feel? You mentioned the patient that you were very close to, you were treating for bladder cancer, and you sort of realized, how can I help you? I don't know how to help you. And I think that points to some of the system-wide failures. Maybe you felt, okay, I think there's a failure in the system, or it's failing me and this patient. How do you think that still plays into the care women receive nowadays? And also, how do you see social media playing a role in correcting that?
I think we're much more public now about the gender bias in healthcare. We all trained in this system that we're like, oh, this is just the way it is, blah, blah, blah. And like, the more we're realizing now, like, why is sexual health only important for men in the healthcare system? 90% of men are heterosexual, right? You've completely failed him if you didn't take care of her. And so it's just like these systemic biases, I think we're getting a lot more comfortable actually speaking about. I mean, if you look at sexual med FDA approvals, men are kicking butt compared to what we have for women. And so there remains a gender bias, but I think being able to speak it is giving a lot of kind of truth to power, to be like, it's not the doctor's fault. We just didn't get taught. And, if you look at who the menopause experts are right now, even the sex med, if you want to go there, they're all self-taught, curious individuals at this point, because they didn't get it in their school, in their training. I mean, I did urology residency, and they told me, we don't know why recurrent UTIs happen.
Yeah, come on.
It's just mind blowing.
Yeah, and now we're like, oh my God, the estrogen goes down, the microbiome changes, the lactobacillus die off. Like, we completely know, and we know, and the treatment's been around since the 1970s.
That's what I mean. We have known. It's just not making it in the curriculum, like you said. Whether it's gender bias, whether big pharma dictates the literature.
Right.
I think there's small parts of all of that, and I agree with you, bringing it to the masses. And that's one of the things we say on our podcast all the time is knowledge is power. We try to bring the knowledge to our patients because it gives you power when you stand in the physician's office to say, I've heard about lactobacillus. I've heard about the changes with my hormones. I know there's something out there. Help me.
Versus I've been on an antibiotic 3 times this year for my UTI, which is just crazy. I mean, I think it should be standard of care. Once you hit a certain age and estrogen is gone, if you're not going to, we just should give everybody estrogen. It should be over the counter at this point. Like, that's how solid it is.
I agree. I mean, like, it's been around for decades. It's very safe. It's over the counter in multiple countries. We have precedents for that. Mm-hmm. And, women in my urology practice over and over again, they'd be like, what do I do when I get another UTI? And I'm like, what if we're asking the wrong question? What if the better question is, how do I prevent the next UTI?
Yeah.
Right. And so it's really changing the mindset. Again, the dogma of medicine is come in when you're broken, we'll fix you, versus preventative health. And how do we not have you get, UTIs are, just pick that for a topic, right? First of all, it costs Medicare $13 billion a year just in recurrent UTI costs. It is actually a massive problem. It can lead to death in some people. Yeah. So amazing paper just published, down to age 20. Women with recurrent UTI who used vaginal estrogen decreased risk of hospitalization, sepsis, ICU admission, and death down to age 20.
Oh, that's fascinating.
Insane.
That's cool.
Yeah.
I'm glad that we're exploring that and doing that research now, because that's what also leads to change. So that kind of stuff is very inspiring.
Yeah, but we know change takes a very long time in medicine, which is where I hope that's where the social media and these platforms get out to, have our patients be a better advocate for themselves, to demand better care before, the doctors get a hold of the science, because how slow things change in the medical world.
Yeah, well, I think another dogma that is I see it a lot on social media is people being like, well, we don't have enough placebo randomized controlled trials.
Oh my gosh.
And I'm like, first of all, the definition of evidence-based medicine, shall we review it? Best available data, clinician experience, desire of the patient. Yeah. That's, if you Google what evidence-based medicine is, it is a 3-pillar, those 3 things.
Like
it does not say,
diagram.
it doesn't say placebo-controlled randomized controlled trials, right?
Correct.
Yeah. And so what we've done is we've kind of, for lack of better words, gaslit, but we're like, but we don't have a placebo-controlled randomized control trial on that. And I'm like, I'm sorry, have you seen the research happening in the United States of America right now? There's not a lot.
Yeah.
Right. And
everybody does.
So to say we can't do something until we get a placebo randomized control trial, you're digging your heels in the sand, and I think you're missing the forest for the trees, and you've certainly lost the meaning of evidence-based medicine.
Yeah.
I had this discussion because, and you've probably experienced this with some of your colleagues who might not be as forward thinking as you and maybe practice more traditional Western medicine. I've got into, let's call them arguments of the minds, where I had a conversation. I'm not even kidding, Dr. Casperson. I posted on social media about eating healthy, avoiding processed carbohydrates, lowering, your glycemic index, and just that will promote your health. And I literally had a local trauma surgeon challenge me for the data and the randomized controlled trials. And I'm just like,
she was dead serious too. And I'm like, are you stupid? I don't even have any
words. Who do you think sponsoring this?
We don't have placebo. And I love, this just to be pedantic. We do not have placebo randomized control trials looking at smoking versus not smoking. We don't have placebo randomized control trials looking at exercise versus not exercise over 40 years, right? Like there's so many things that are like no brainers that we've never done a placebo control. And there's one variable that's changed in a randomized placebo-controlled trial, and that's not how humans are. Right. So it's like people don't understand the limitation of said control trials.
Yeah.
And I'll, just to pick on them for one more moment, people will say the largest placebo-controlled randomized controlled trial for testosterone in women didn't show benefit for mood. And then they'll use that to say, testosterone doesn't help mood, basically, is what they'll say. That trial ran for 8 weeks. Everybody in that trial had failed at least one antidepressant. So to me, I'm like, you can't say, use that one randomized placebo-controlled trial as dogma. It doesn't apply to the general population.
Right.
And furthermore, testosterone can take 6 months, 12 months to do its magic, right? So even though we'll use the placebo randomized controlled trials against us and use them as dogma, even though they were 8 weeks long with 80 people who had already failed multiple antidepressants.
Yeah. Which we know in clinical practice, when we prescribe testosterone, that our females come back and say, oh my gosh, I can get my in our practice, we call that the get shit done hormone. Like that is your neurocognitive functioning. And we know that. I don't need a paper to have my patient know that that's happening.
And going back to what is evidence-based medicine, that's what you just said. Clinician experience. Yeah. And that is completely being dismissed in this world of like, let's just have AI do all of this and let's just follow the available data is like, there are people who do this day in and day out. And I mean, that's how good research comes about. People being like, you know what I've noticed over 10 years in practice?
Yep.
Let's study this.
Boom.
Right. But we've dismissed clinicians and their expertise. I think we've devalued that. And we're just missing the forest for the trees.
Yeah, I agree. And we've actually done a podcast where we sort of talked about this. And this isn't really for this one, but just to mention, evidence-based medicine, or what people think of that, is also very heavily dictated by the methods that are used, the way the data is interpreted. There's so much manipulation that can come into play that even randomized placebo-controlled studies can be manipulated heavily. And it's just so hard to fall back on anything nowadays. So I get frustrated with that.
And what's published in the abstract, it can be published as a negative study, but then when you read the study, you're like, there's really good stuff in here. Right. Yeah. But it just wasn't their primary endpoint. And so it's like understanding the expert, understanding the papers, like it's complicated, big stuff, but to use it against people, I think is dismissive.
Yeah, it's I feel like a bunch of lies. Speaking of, what do you think the biggest lie women are told about menopause when you see them in your office or even just out and about, or the people that you take care of? What do you think the biggest lie that you hear that women are told?
oh God, Lord, there's like 5 of them.
I know.
That,
Give me your top
that hormones are dangerous, that this is natural and therefore we shouldn't treat it. Like, that's stupid. Yeah. Like, getting a baby stuck in a birth canal is natural and we treat it, right? So it's like this myth of natural. I would say those 2 things, just kind of this dismissal. Like, we never tell a man that erectile dysfunction is natural and he should just leave that. Like, sure. I'm sorry, you're too old for a hard penis now. Like, yeah, we've never said that to a man.
Right.
And so again, it's like the gender bias, right? Of like, high blood pressure is natural. We treat it. So
yeah,
I just think it's this myth of natural, this naturalistic fallacy that somehow we use that to prevent access to women.
Do you find women respond when you explain it like that? Or is there a different way you would explain it to a patient?
I mean, this is what I do. I'm like, what's on your feet? And they're like, shoes. I'm like, it's not natural. Why are you doing that? How'd you get to my office? Car. It's not natural. Why'd you do that? Yeah. Right? Because you can cut down natural. So if air conditioning, are you kidding me? Right? And so it's like to pick one thing as the thing you shouldn't treat because it's natural, like the thesis just falls apart in a millisecond. Mostly I like to point out people's socks. I'm like, you're wearing socks.
Yeah.
Not natural.
Not natural.
And
but socks make your life better.
Right. And all of these patients that are already on multiple pharmaceuticals, like, SSRIs and all these other things, or like you said, the husbands that are getting the treatment that, that's not natural, that we call that, and we throw them on medication, but nobody's ever sitting back to say, well, who's treating these females that have to deal with the men who are getting the ED medication? Like, it's just this vicious circle that we constantly feel like we have to battle and fight for our own, our rights. It's crazy.
It's a lot more work. It's a lot more work, I think. And I think we're starting to be able to say that. Yeah. But it's a lot more work to get care. There's a paper just published looking at an insurance database in America. And these were women who made it to a doctor and got a menopause diagnosis. So think of all the women who don't make it, right? So they've already done 2 gauntlet hurdles. 30% of them were treated, which means 70% of them were not treated. And we know hormones are the gold standard for menopausal symptoms. Like, every paper says gold standard for menopause. There are other options, but hormones are gold standard. You got the gold standard 30% of the time, like less than a flip of a coin.
Yeah. It's unacceptable.
It's crazy.
Yeah.
That makes me think we get so many patients that talk to us and we hear, I went and saw my provider. I talked to them. Your labs are normal. This is normal. This is normal for aging. This is how you age. What sort of message do you say to that when someone maybe comes to you from someone else with that? My labs are normal. I'm told it's normal.
I mean, again, I'll blame the system more than I'll blame humans.
Yeah.
It's very, very hard to listen in a 10-minute visit. It's a lot easier if your femur's sticking out of your leg, right? Like, I believe you. I see this. Right. It's a lot harder to be like, Susie doesn't feel like Susie, and that's meaningful. And so to me, I'll do this with labs because people are like, what are the ideal labs for pick a hormone, right? I'm like, how does she feel? Does she have any side effects? And then what are labs? And what we've done in this scenario is we've put labs before the human. And I think we're fundamentally forgetting what healthcare is about when we do that.
Yeah. 100%. And then you have providers who don't even know how to interpret those. So you get a PCP who will run hormone labs, and then a patient will come to me for metabolic health, and they're like, my PCP tested my hormones. They said everything looks great. And I'm like, but you're 65 and you're post-meno. Like, what do you mean? You mean it's just missing? Like, that's what looks great?
It was
like, they
zero,
have no
so
idea how to even interpret that. So then she's like, what do you mean I don't have hormones? And it's like these patients don't even understand what's happening in their body. And I'm like, oh my gosh, like, we got some work to do, which is why it's just so big to understand. Like, you have to understand that labs are never just the end of the story ever, especially with hormones.
Well, and I think the branding, I'll call it branding for lack of a better name, the branding of menopause is like, no more periods. And I'm like, that's a symptom of what's actually going on.
Right.
Right. And by the way, you need a very small amount of hormones to have a period.
Yep.
Right. So, to me, I'm like, listen, this definition got invented centuries ago when all we had was like, is somebody bleeding or not? That's all we had. Right. We couldn't measure hormones. We couldn't see how many follicles were left on the ovaries, but we know better now, but we're still calling this menopause.
Yeah. And they think
which means no periods.
Yeah.
Which 1/3 of women don't have periods anyways because of hysterectomy, IUD, whatever, ablations. So to me, I'm like, you're right. People don't fundamentally understand that this is hypogonadism, which can have consequences if you choose to live hypogonadal for decades. And again, you know,
Right,
people they'll call on me and they'll be like, you just want everybody to be on hormones. And I say, no, I want everybody to know what's going on, to be able to advocate and to be able to choose to take them or not. Like that is my platform, because to me, I'm like, your body, your choice, but go in being educated and informed.
We absolutely echo those sentiments,
that.
and I think that's what all the time. It's just about education. Listen, it doesn't change my day if you do this or not. Like I want this for you, but if not, we're okay.
Yeah.
You know, we're still having dinner and
right. And that's what I tell my patients too. Yeah,
totally. And like for me, you know, the people say on, you know, the menopause and stuff, like all you care about is hormones, and I'm like, dude, there's still nothing better than exercise. Like there's still nothing, like just extra, like everybody thinks it's this all or nothing. And if you can't have it all, you're up a creek. And it's like, are you sleeping? Right. Are you exercising? Can you stop drinking alcohol for like 1 hot minute and think about this? So I think people want to use hormones as this like panacea for like getting out of doing the other work of being healthy. But it's like, no, but if you want hormones, I think you should have access to them.
Mm-hmm.
You touched on a great point that I want to bring up, and the providers who think like us and talk to their patients like we do absolutely talk about those things. I mean, we talk about wearables, we talk about the amount of sleep, and a big thing you mentioned is alcohol. I feel the tide shifting, and if you look at the data, you know, the people under 50 are definitely drinking less alcohol than people over 50. How do you feel that affects women as they age, and what's your advice to your patients?
There are two things that I'd say women are most afraid of. First of all, we're not afraid enough about heart disease, but that's another topic. Like people are like, number one killer, we're not afraid of that at all. That's very weird. Yeah. But women are afraid of breast cancer and they're afraid of dementia.
Yep.
The top two fears. Right. Yeah. And I really got into it. I mean, I haven't had alcohol in 5 years now. And I got into it because I'm like, I just want the next personal growth challenge. Let's see how hard this is. And in doing that, I became, again, self-educated on what actually is alcohol. How does it work? What does it do to the brain? Should we revisit the studies that say wine is good? Oh, sponsored by the wine industry. Fascinating. Right. So
shocker.
Going back through all of that, and women, and again, tying into hormones, women are like, well, I don't want vaginal estrogen because I don't want breast cancer. Like, again, the myths of the hormones. Mm-hmm. And I'm like, do you drink wine? Right? Like,
because that increases your risk.
It increases your risk. It increases the risk of 8 cancers by the WHO.
It's a carcinogen, known carcinogen, right?
Yeah, it's bad for cells, right? Where I think, you know, hormones help healthy cells stay healthy. Alcohol does not. It can kill cells. We use it for an antiseptic. And so it's just this grand paradox of we're afraid of the wrong thing. And how many people will fight for their, you know, cheap, tasty dopamine source?
Yeah, you'll get those patients that come in and they're like, oh, I'm really scared of hormones, but they're drinking, they're vaping, they're morbidly obese. And I'm like, you have 3 right off the rip that's going to put you at significantly greater risk than anything I'll ever do to you. Like, it's just, their mindset is just so backwards. And that's where I'll have the conversation. Listen, I can tell you all the things that I know, and it doesn't make a lick of difference in my life if you start hormones or not. But I'll be damned if you do go into this just fear-mongered and throw the baby out with the bathwater and not understand why you're saying yes or no. It doesn't matter to me, but you're going to be educated in your decision.
You're going to know.
Yeah. You're going to know my thoughts.
Yeah. I think the other thing that blows my mind, I'm like, people aren't afraid enough of high blood pressure.
Yeah.
And I'm like, you're just walking around at, 150 over 90. I'm like, dude, because women, I would say, are afraid of strokes. Biggest stroke risk, high blood pressure.
Yeah. Agreed.
And I'm like, you guys, high blood pressure is really bad for you. Like,
probably
treat
one
that.
Of the most, like you said, one of the most underrated cardiovascular risk factor when you start looking at the data for mortality, 10-year mortality and things. And I agree, it's not monitored enough. And so many things that we mentioned, vaping, drinking, smoking, exercise, all of that plays a role in blood pressure, plays a role in hormones. I mean, just absolutely essential.
Yeah,
totally.
Yep. And I feel like we have to fight people on, like we were talking about the Women's Health Initiative, and I wanted to pick your brain on this. So obviously, 20 years after the Women's Health Initiative, we're still seeing women that, like you said, are absolutely terrified. So when you have somebody in your office that you only have a minute maybe to explain to your patient, what the evidence actually says, what are your go-to points to make them like really start thinking that there might be something else to look into with this?
Yeah. So the first thing I do is like, where did you hear, if they say estrogen's bad or blah, 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 where did you hear that from? Because I basically want them to cite their sources, right?
Sure.
Because 9 times out of 10, they'll be like, I don't know. And I'm like, oh, so you're saying something as if it's a fact, but you can't tell me where that fact has come from. Very interesting. Right. So I just kind of like want to pull and kind of pick, I think we're driven by limiting beliefs. Right. So if I can like pick apart your limiting belief and be like, oh, I think something's a fact, but I can't back it up. That's curious. Yeah. And then I'll do just some other thought exercises. I'll be like, well, if estrogen causes cancer, how come the majority of breast cancer people are post-menopause when they don't have estrogen in their body? Mm-hmm. And if estrogen causes cancer, how come pregnant women aren't getting breast cancer left and right?
Yeah.
Heaven forbid triplets or something, right?
Yeah. It's high estrogen.
Yeah. And so I'll just start pulling, if estrogen causes cancer, why don't more men have it? Because they have higher estrogen than women do after menopause.
Yeah.
Right. So just thought exercises. I'm not here to say you're right or you're wrong. I'm here to just try to put a little bit of sunshine in the dark room that is your certainty.
Mm-hmm.
Yeah, I think it stuck with me in a menopause moment where you did say that question, why, if estrogen causes cancer, why isn't pregnancy a risk for breast cancer? And that one is the one that stuck in my head a lot.
Yeah. And isn't it shown to be protective, if I remember?
Yeah, it's shown to be protective. I mean,
yeah,
it's so... You're never going to get how do you randomize placebo-controlled trial pregnancy, right? So like it's imperfect data, just going back to imperfect data, but it suggests that pregnancy is breast cancer protective.
Yeah.
We, absolutely love the views that you're sharing. We're running a little bit low on time, and we definitely wanted to make sure people understand that they will have plenty of time to hear you talk on October 10th in Toledo, Ohio at the Northwest Ohio Women's Health Summit. You are going to be one of the keynote speakers, and you're also going to be having a fireside chat with Mia. That's going to be very exciting, where we will have this sort of discussion.
Those are my favorite.
Yeah.
Those are my favorite.
Mia, you had one other question we wanted to drop on her before we're done. Just her other practice. It's not just hormones, it's also sex.
Yes. So that is a big elephant in the room. And a lot of times patients don't like to talk about that. So what's one conversation about sex that you wish that every couple in midlife would have, but almost nobody's talking about it?
Yeah. I mean, sex is so fascinating, and it's like such a big topic. And I just think it's like a fascinating topic, right? Like, we're literally all here because somebody had sex. Isn't that interesting? Like, that's so interesting. Like, what if your dad like had an extra glass of wine that night, or your mom like was late at work? You wouldn't exist.
Yeah.
Right. So I kind of just like to like explore how fascinating that is. Like, a male ejaculate is like, what, off the top of my head, 180 million sperm. Right?
Mind blown.
The fact that you're here because of a sexual event is absolutely mind blowing. So if I can get a little bit of awe and wonder into people's brains, then I've got them, because it is actually a very fascinating topic. And then they tend to like get mad about how poorly they were trained about it.
Yeah.
Right. And now you've got them talking.
Yep.
And then you talk about it and everybody thinks this is fascinating. And then you're like, oh, see, nobody died. We don't die talking about sex.
Right.
But it's this whole, like, people's apprehension is like, I want to talk about it. So you just get them talking about it. And then you're like, this is fascinating. Like, it's super fascinating. Right. And so I think just talking about it and the modern world, probably because of video, there's a lot of like spectatoring or perfection. Like, we forget it's supposed to be this like fun, light, pleasurable. Like, we've kind of put like Olympic, responsibilities on this like athletic experience. And we're like, dude, you don't actually have to take it super seriously.
Yeah.
But I think the first thing is like realizing you're not going to die when you talk about it.
Right. And we made a point on all of our hormone visits. We have a box that basically discusses that. Like, how's your libido? How's your sex drive? Do you have difficulty climaxing? Like, all the things that they're like, I've never been asked those questions in my primary care or OB or whatever. And I'm like, I know. That's why we're going to talk about them, because I know that it's a problem. And 90% of the time, my females are like, oh, thank God. Like, I didn't even know that I could fix that. And I'm like, yes, we can work on your relationships, and there's some books to read, and here's some things to help you, like testosterone testosterone. And my husband and I watched the Pink Pill movie. Is that what it's called?
We did
the
watch
documentary about
Yeah.
fulvestrant or the Addie. And I'm like mind blown. I'm like, there's so many things that we can do to support our women, but I can't help you if I don't know your issues. And so we made it a point to bring that in there. And I find it's closing that gap to say, oh my gosh, I can talk about things that are way too intimate from, what I thought that I could talk about. So it's great.
Yeah. I mean, it just, again, tying it up with a bow with gender disparity is Viagra came on the market in 1998.
Yeah.
Yeah.
So we're that many decades away from equality. So we've disrupted relationships by being like, erections matter. Don't ask her anything. You know,
Right.
so it's we got to level the playing field. That's like our lowest bar is like, we just got to level the playing field because we've got so many, Viagra, Cialis, like so many options for guys, but like it's not a successful event if she didn't get helped and she's not using vaginal estrogen and she doesn't understand orgasms actually come from the clitoris and not the vagina. And, it's just like the basic 101s as a society we're missing. So I clearly, my podcast can keep going until I'm 84 years old because the topic of sex is like so big.
I hope it does.
Not that I would ever do this, especially as a man. It probably wouldn't be comfortable. But I liked in that documentary, The Pink Pill, where the one, I believe she was an OBGYN, was talking about how she actually hands her patients a mirror and like teaches them about their vagina, like points to the structures, has them look at it, like look at your vagina, learn your vagina. It's pretty interesting.
It's crazy. And like you said, just the gap in care. That Viagra hit the market in like 30 seconds, and then females are still fighting for their rights on their turn. So it's just closing the gaps. But it's people like you that'll really help change the world.
Viagra was deemed such an important breakthrough medication that the FDA put it through with less than 6 months safety data.
Yeah.
Like that, like super important medication, right? Which I won't argue with. I'm just saying, where's the female dose testosterone?
Correct. In not having,
it's been 80 years since they started giving that to women.
I know. It blows my mind. We have lots to do. And I love your movements with the FDA and all the things. So, I'm very excited to see what the future brings for you, too. You're one of my favorite educators.
Yes.
Thank
Dr.
you.
Casperson, thank you so much for taking the time to join us on Health Without the System today. We really look forward to seeing you in Toledo on October 10th. Your health is one of the greatest investments you'll ever make. Join us October 10th at the Northwest Ohio Women's Health Summit in Toledo, Ohio. Visit our website or click on the link below to reserve your spot today. We can't wait to see you there.
Thanks, guys. This podcast is for educational and conversation, not medical advice. It is not a replacement for personalized care, diagnosis, and/or treatment. Always talk to your own healthcare provider before making changes to your health, medications, or lifestyle. Our goal is to give you better questions, better understanding of disease, and more ownership of your health. Knowledge is power. We'll see you guys next week. Thank you.